You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is September 30th, 2024. We will be finishing How the Immune System Works by Dr. Lauren Sompayrac and discussing chapters 13 through 17. This is presented by Dr. Nikita Raje. She is an associate professor of internal medicine pediatrics and is the chief in the section of allergy immunology.
Okay, sounds good. I restarted it.
All right. So let's go through the first few slides. We're going to talk about still on Sompayrac textbook, last day today. And here are my disclosures. Nothing relevant to the talk. And again, we are going to be talking about chapters 13 to 17, really very short presentation today. I'm not going to go into a lot of details. I encourage you to read up and, take notes of all the details in these chapters, but I'm just focusing on a few facts here and really want to go ahead and finish the Jeopardy today. So again, I'm Nikita Raje from Children's Mercy, Kansas City, University of Missouri, Kansas City, and today is September 30th, 2024. So we'll be talking about immunodeficiencies, vaccines, cancer and the immune system, immunotherapy, and COVID-19 and the immune system. So let's start with the first being chapter 13, immunodeficiencies. And really, I just wanted to give you an idea of what Sompayrac textbook mentions. It mentions how there are several immunodeficiencies depending on where the defect is. It can affect the innate immune system or the adaptive immune system, as well as just kind of keeping in mind that there are several genes. At this point, we know more than 500, and the list keeps growing, but there are several defects that can occur where you don't see immunodeficiencies just because there is a backup plan. There are several places where the immune system has a backup, because of which you don't notice a defect because some other player takes up that job, and that's the reason we don't see any symptoms from the defect. So there are a lot of functionally redundant immune system players, because of which you may not see a problem with a lot of defects that can occur. So if you think about the immune system, if it affects T and B cells, so if it affects both the cells and they are absent, mainly the T cells completely absent, it causes severe combined immunodeficiency. It affects the B cell function as well, and so it's called a combined immunodeficiency. There are several other combined immunodeficiencies and immunodeficiency syndromes. One such important one mentioned here is CD40 ligand defect that causes hyper IgM syndrome, where the T and B cells are enough in number but are unable to communicate with each other or perform the function of class switching from IgM to other immunoglobulin classes. There can be defect in innate immune system, such as complement system, and if there is a defect in complements, such as complement 3 fragment, it can give rise to immunodeficiency, where you may see that there are lymph nodes but no germinal centers, and so the B cells can also get affected, and they produce mainly IgM antibodies. Defect in neutrophils and can be because of adhesion molecule issues, and that causes leukocyte adhesion defects. There can be absence of mature B cells, such as in A-gamma globulinemia, leading to absence of antibodies. There are immune dysregulatory disorders, such as Treg defects, that can cause the prototype of that is IPEX, caused by FOXP3 defect. We learned last time that the Tregs, the main marker, is CD4 positive cells with FOXP3. So if the FOXP3 gene is defective, it gives rise to IPEX syndrome. Then there are other innate immune defects such as toll-like receptor defects, and they have very typical features such as TLR3 pathway defects leads to HSV encephalitis, IRAC and IRAC defect, or one more escapes my mind right now. IRAC4 defect causes problems with biogenic organism infections that are pretty severe, such as sepsis, and even with that you would see absence of inflammatory marker elevation, so no elevation in CRP or ESR. You may not have fevers with that presentation. So MyD88 and IRAC4 defects. There can be autoinflammatory defects such as defect in IL-1 receptors, so DIRA, defect in IL-1 receptors. So that the short form is DIRA, and that gives rise to a lot of autoinflammatory symptoms. And of course, there is a long list of other autoinflammatory syndromes as well. And then there is a category of bone marrow failure defects that leads to significant immunodeficiency just from not having the immune cells. So a lot of different types of immunodeficiencies. These are all primary immune defects, which means the defect is in the immune system itself, whereas there are secondary immunodeficiencies, which are way more common than the rare primary immunodeficiencies. And so secondary immunodeficiencies are caused by defects somewhere else, or caused by medications, or malignancies, or viruses. And one such secondary immunodeficiency is caused by HIV virus that can lead to AIDS. So here the figure shows how there is an acute phase of HIV infection that where the virus peaks in 3 to 4 weeks, and over a period of time the virus count goes down, virus load goes down. After that acute phase, the virus-specific CTLs and helper T cells continue to be present when the infection goes into the chronic phase. And after a period of time in natural infection, if it is not curbed by medications, it would cause profound immunosuppression where both T helper cells and the cytotoxic T cells will lower down, the virus load would go up, and that's when you would see opportunistic infections. The antiretroviral therapy is pretty important in treatment of these patients, because with the newer agents that are now available, these patients can be pretty much asymptomatic, and the viral load can be undetectable for a very long period of time. So in general, kind of thinking about what happens when the infection starts, HIV virus would enter through rectum or vagina, and then it would infect the helper T cells, and those helper T cells are gonna proliferate, initially cause the virus to proliferate. The virus would use the machinery of those helper T cells, and then after a week or so, when the adaptive immune, so after the innate immune response starts and the adaptive immune response kicks in, there are virus-specific B cells and helper T cells and cytotoxic T cells that get activated, and that's when you see the acute phase of the viral infection. So that's HIV infection. In really short, you can read the details. We'll move on to the next chapter on vaccines. We know that there are two types of vaccines, inactivated or non-infectious vaccines versus live attenuated vaccines. So what's the big difference from immune response point of view? So you would see memory T helper as well as B cell response when vaccines are given that are inactivated, versus when you give live attenuated vaccines, they they cause a response from from B cells as well as both memory T helper cells and cytotoxic T cells. So that CTL response is important. That is present only when you use the live attenuated vaccines. So there are different kinds of vaccines. The kill vaccines, where the virus is completely killed and treated with formaldehyde, such as polio or influenza, and then used as vaccine. That's your killed vaccines. Versus in terms of toxoids that are used for vaccines like diphtheria and tetanus, those toxoids are purified and then treated with aluminum salts. There are acellular vaccines, which means only a part of the cell is used, such as in pertussis. Subunit vaccine is where the viral protein is produced by genetic engineering, like hepatitis B or HPV vaccines. Then there are carrier vaccines, where the gene for that virus is introduced gene is introduced into the virus like a Trojan horse and used as the vaccine. And then the mRNA vaccine that we know of, such as that was used for COVID-19. Live attenuated vaccines, MMR, varicella are important examples. Other live attenuated vaccines are rotavirus or yellow fever vaccines. The immune response that comes from CTL is different from the non-infectious, as we mentioned, but it also is important that live attenuated vaccine can lead to herd immunity. Unfortunately, these vaccines can lead to infection in immunosuppressed individuals. Also, a mutation can be caused that leads to disease in immunocompetent host once in a while. So that's the risk of these vaccines. So when you use the killed vaccine, we use adjuvants. We add adjuvants to these vaccines, and the reason for that is a concept of how that coach and the quarterback play comes into effect. So we know that the antigen presenting cells are the key to letting the adaptive immune system know that there is a problem, right? And that is an important signal, that second signal that is needed to to produce an immune response at any given point to any antigen. So if a vaccine is given and it gives the primary signal, which means it comes in contact with the immune cells, it will be detected, but it has to also provide a signal that it is a danger molecule for the immune response to occur. So the adjuvants help in providing that second signal or danger signal. So the foreign signal is provided by the protein itself, the microbial protein in that vaccine. But the danger signal is provided by the adjuvant if a non-whole killed vaccine is used, and at those times, without that, the immune response may not be produced. So the adjuvants used typically are aluminum salts like aluminum hydroxide or alum, and MPL, modified LPS, that can be also used as an adjuvant. All right, moving on, we'll talk about the cancer and the immune system response. So thinking about how cancers develop, there are genes called proto-oncogenes, which means if there is a variant or a mutation in these genes, it can lead to proliferation of cells that lead to cancer. If that mutation occurs, those genes, proto-oncogenes, are called oncogenes. There are also another type of genes called tumor suppressor genes. They code for proteins that are tumor suppressing proteins. These are important genes the proteins such as P53 that helps in preventing cancers in our body. There are several types of malignancies, as we know, carcinomas and sarcomas. There are blood cancers such as leukemias and lymphomas, kind of keeping in mind that these cancers can develop spontaneously, or they can be virus associated. One of the factors that can lead to development of cancer. There are some agents that can lead to development of mutations that lead to the occurrence of cancer, and those are called carcinogens. So our body has a system to provide surveillance against this cancer producing genes or proteins, and that's provided by CTLs, cytotoxic T cells, natural killer cells, as well as macrophages. All right, moving on, talking about immunotherapy. A couple of types of immunotherapy that we want to talk about is monoclonal antibodies as well as CAR T cells. So where are monoclonal antibodies produced from? They are produced from a platform that is created called hybridomas. So a couple of scientists came up with this idea where they noticed that the cancerous B cells can become immortal and they can proliferate to produce several such B cells, but unfortunately, they do not produce the antibodies of our choice. But with this kind of platform called hybridomas, the immortal cancerous B cells can be fused to a plasma B cell that makes antibodies of particular choice, the desired antibodies. And once those two cells fuse, they lead to formation of a hybridoma or immortal antibody factory. So that hybridoma will then produce a large number of antibodies of desired choice. Another type of immunotherapy is provided by CAR T cells. So CAR T cells are based on the concept that T cells to be activated need that first signal and the second signal. So first signal is for the binding of the target to the particular antigen receptor, and then it needs the signaling molecule. So for T cells, it's CD3 zeta chain, or it could be any other chain, but in this case, in CAR T cells, they use CD3 zeta chain, as well as they need a second signal that's provided by CD28. So it needs that co-stimulator. So in this case, in formation of CAR T cells, they use the concept of Greek mythology that has the head of the lion, body of the goat, and then tail of the dragon. And so that's how this is conceptualized, where the binding of the target is to a single heavy and light chain domain that is attached to the CD3 zeta chain as well as the CD28 chain, and all together can target particular antigens, and so the CAR stands for chimeric antigen receptor T cells. Last chapter, COVID-19 and the immune systems. We know that COVID-19 is caused by SARS-CoV-2 virus. It is one of the largest RNA viruses, and it's a single-stranded RNA virus with 30,000 bases. What does it do? It infects ACE2 receptors. These receptors are present, as we know, in respiratory epithelium, as well as GI tract and some cells that also have these receptors. When SARS-CoV-2 infects the body, there is an immune response that's provided by the innate immune system as well as adaptive immune system. So we know that there are pattern recognition receptors such as toll-like receptors 3, 7, 8 that target single-stranded RNA. There is apart from the pattern recognition receptors, once those are activated or recognize the antigen, they will lead to lead to the activation of some of the innate immune processes, such as antiviral response. Type 1 interferons are the ones that help in antiviral response, as well as some of the other cells that are present in the tissue where they enter. So, such as in respiratory tract, there are interstitial macrophages as well as alveolar macrophages that take part in the immune response. Once the innate immune system activates the adaptive immune system, these cells that get activated produce IgG and IgA, as well as the helper T cells get activated and help in that immune response. And that's because of the presence of the lymphoid organs, so nasal associated lymphoid tissue, or NALT, or BALT, that's bronchus associated lymphoid tissue. That's where these adaptive immune cells reside, and that's where they get activated. So that's just some immune response to COVID-19 in a nutshell. Of course, there are more details in the chapter that I'll let you guys read. And now we can move on to the Jeopardy. So let me